Hello, everyone. Thank you for joining us today for the Essential Together Huddle. My name is Jill Ritchie, and I will be your host today. Please note that this session is being recorded, and the recording will be available after the session. We are once again pleased to offer this session as a bilingual event using simultaneous interpretation. Please select from the interpretation menu to hear the session in French, and please access the View Options menu at the top of the slides to see the slides in the language of your choice. At Healthcare Excellence Canada, we are early in our journey of reconciliation and how we develop meaningful relationships and partnerships with First Nations, Inuit, and Métis governments, organizations, and communities. As part of this journey and in our strategic plan, we strive to support cultural safety and humility in the healthcare system and enhance the capacity of the health system to meet the needs of First Nations, Inuit, and Métis. I join you today from the traditional lands of the Anishinaabe and Haudenosaunee peoples. Before it became known as Peterborough, Ontario, this area was called Nogo-Jiwanam, which is Ojibwe for the place at the end of the rapids, which is a beautiful way to describe where I'm located. This area is known for its lakes, rivers, and forests, and I am grateful for the opportunities to enjoy this land, hiking, canoeing, and skiing. Please take a moment to introduce yourself in the chat box and let us know and reflect upon the territory where you are joining us from. If you are unfamiliar with the territory you are on, we have shared the link to a great resource, Native Land Digital, in the chat box. As many of you are aware, we at Healthcare Excellence Canada are firmly committed to partnering meaningfully with patients, caregivers, and communities to shape the future where everyone in Canada has safe and high quality healthcare. And we recognize that purposeful patient engagement is fundamental to transforming the health system and improving quality and safety of care. We know that patients, caregivers, and community members offer insights that can lead to more sustainable improvements in healthcare and health systems that better meet their needs. We welcome your participation in today's session. For those of you who may be new to these huddles, the program of Essential Together was developed to support the safe reintegration of essential care partners into health and care settings throughout the pandemic. In particular, Essential Together supports organizations to welcome back essential care partners by presenting the evidence, providing policy guidance, learning in these national huddles, additional resources, tools, as well as a pledge and a change package, which are posted on our website. Foundational to all of this work, including the original policy guidance, are three principles to truly welcome essential care partners as partners in care. Differentiate between visitors and family caregivers as essential care partners, recognize the value of caregivers as essential care partners, and ensure patients, families, and caregivers have a voice in the development of policies related to visitors and essential care partners by engaging patients, residents, families, caregivers in all aspects of care and delivery, including policymaking. It's my pleasure today to welcome our speakers. Michelle Sam is a passionate visionary leader who is able to transform organizational strategy into quality programs and best practice. She joined Oak Valley Health in December 2016 and is currently the Director of Quality, Patient Experience and Relations, Patient Safety, and Infection Prevention and Control. In her role, she is responsible for ensuring excellence in the advancement of continuous quality improvement at all levels of the organization and beyond the hospital's walls. She is also responsible for the strategic development, planning, execution, and oversight of patient experience. I'd like to also introduce Elaine Richards. Elaine is a quality, patient safety, and risk leader with over 15 years of expertise in quality systems, driving innovative processes and programs to achieve quality excellence. Elaine brings a demonstrated commitment to patient safety, supporting healthcare teams to improve the quality of care and safety of our patients. She is recognized for her transformational leadership in the development, implementation, and execution of plans to support strategic goals, and is currently the manager of quality and patient safety at Oak Valley Health. She holds a Bachelor of Science in Nursing, is a certified patient safety officer, and many other great credentials. Kanwal Ali, our third speaker today, is a quality and patient safety specialist who is passionate about continuously improving the patient experience at Oak Valley Health. She leads with a collaborative, dynamic mindset focused on operational excellence, developed through 15 years of cross-industry experience in food and beverage manufacturing, end-to-end supply chain, and healthcare. She is highly analytical and believes in developing a culture of people-centered care through listening to and learning from patients and families. Kanwal is a licensed professional engineer by background, holding an industrial engineering degree from the University of Toronto and a Lean Six Sigma Green Belt designation. And it is my pleasure to introduce them as today's speakers.
Okay, thank you, everyone. I will get us kick off with our presentation. If we move to the next slide, I'll talk a little bit about Oak Valley Health. Oak Valley Health is a large community hospital with 3 sites. Our biggest site is our Markham Stouffville Hospital site. Our smaller site is our Uxbridge Hospital site. We also have a ward at our Reactivation Care Centre Finch site. Our hospital provides high-quality, patient-centered care to over 437,000 patients each year across all 3 sites. We provide a range of services. On the next slide, you will see we have an emergency department that's very busy and active. We have diagnostic imaging services. We have clinical programs from a medicine perspective, surgical, addiction and mental health, our children and childbirth services. So we do provide a range of services to our community. On the next slide, you will see, like all hospitals, we have our mission and vision, which really speaks to our purpose and the value we bring to the healthcare system. We actively engage and partner with patients and families, and you can see this as it's articulated our commitment to patient and family-centered care in our patient declaration of values. And these values sit alongside our own hospital values in regards to what we pledge to our community. On the next slide, what you would see is that over the last 3 years, patient and family-centered care has remained a priority for the hospital. However, it has become a balancing act as we continuously try to balance the needs of patients, live true to our patient and family-centered care values, as well as concerns from our staff stemming from fears of allowing visitors in hospital. So in essence, we had a really strong patient and family-centered care, as well as family presence policies and guiding documents, which was for the most part disrupted during the pandemic. I'll hand it over to Kanwal to talk about the steps we took to get us back to where we were prior to the pandemic.
Great, thank you, Michelle. So what you'll see here on the screen is a bit of a snapshot, our journey throughout the last few years. As Michelle mentioned, prior to 2019 and the onset of the pandemic, we had implemented a Better Together family presence policy in 2017. So our hospital was well known for an open and inclusive atmosphere, very welcoming to family presence, with 24/7 access for care partners in most hospital areas. With the onset of the pandemic, particularly during wave 1, we, like many other healthcare organizations, implemented no visitor policies in order to limit spread within the hospital and prevent community transmission. We did, however, introduce new virtual visiting guidelines that were developed and implemented across all hospital areas. Throughout 2020 and 21, we continued to limit visits and then slowly started to open our doors back up. There was much evidence, both internally and provided externally, to show the impact that limiting visitors was having on patients and their loved ones. So we came up with some new strategies. We developed guidelines for limited in-person visiting, and then started some new programs, including compassionate rounding, where redeployed outpatient mental health staff would visit with at-risk patients to provide care and comfort, as well as the development of messages of love, where messages provided by loved ones would be hand-delivered to patients in the hospital. In 2021 and 22, we developed a program for visitor navigation. As our guidelines continued to evolve, we hired this role specifically to manage and schedule visits on the units, as well as piloted our essential caregiver program. And over the last fiscal year, we've been proud to spread and scale this program across the hospital, as well as transition back to 24/7 visiting in most hospital areas. Next slide, please. So going back to about a year and a half ago, we decided to implement the Essential Together Essential Caregiver Program at Oak Valley Health. Looking at how we designed this, the first piece of the puzzle was stakeholder alignment. So communicating clearly to all the different stakeholders within the hospital to bring us back to one common mission. So this included alignment with our senior leadership team, addressing any privacy concerns, engaging IMIT, talking to all of the leadership in the different areas throughout the hospital to help them understand what this program would entail. We then conducted a best practice review. So this included a lot of the learning bundles that were available from Healthcare Excellence Canada. This allowed us to see what was currently being implemented by other healthcare organizations, and then modify and adapt and adopt resources that made sense for us. The next step was quite a bit of iterative co-design. And this is where we really heavily relied on our patient experience participants, or PEPs, which are the patient advisors at our hospital. So this is a highly engaged team of former patients, loved ones of patients, who helped us develop the intake process for the program. They helped us develop all of the supplemental guidelines and materials through a process of many iterations. We developed a pilot plan, so identified which areas it would be ideal to start in and developed a timeline for spread and scale. And of course, developed a measurement plan. So a way to track our success, understand different process and outcome measures, as well as identify challenges along the way. Next slide, please. So what you'll see on the screen here are some examples of the resources that were developed. What you will see is a snapshot of our Essential Caregiver Guidebook, which really became a tool not only for staff, but for patients and their loved ones as well. So this includes guidelines about what to expect as a member of the program, as well as policies you are required to adhere to, the importance of privacy and confidentiality when you are enrolled in the program, as well as what to expect when you are on site. You will also see a snapshot of our Essential Caregiver Commitment Form. And this was very important to set those mutual expectations right from the beginning of enrollment. It is a commitment between the caregiver and the hospital, identifying the exact roles and expectations. Next slide, please. Here you will see the Caregiver ID that was developed, and a key part of this program was that each caregiver was given an identification badge to wear while on site, really highlighting them as a valued member of the care team and not someone who was coming for a casual visit. There was also a brochure that was developed, again, through many iterations with our patient experience participants, serving as an educational tool for potential caregivers and really highlighting the difference between caregiver and visitor. Next slide, please. So one of the key components of our success with this program was building partnership between our team as the quality, safety, and patient experience team and staff throughout the hospital, partnership with patients and their loved ones who would then become caregivers. So the three key components of that partnership were developing those mutual expectations right up front, clarifying roles and responsibilities, and defining role limitations. Detailed in the guidebook, some of the roles and responsibilities include help with activities of daily living. So caregivers could assist with feeding, toileting, mobility with specific training from the healthcare team. They were there to provide cognitive support, emotional support, and to be a warm presence for their loved one. Limitations were also defined to ensure that caregivers knew not to administer medication, to touch important medical equipment, or to provide care to anyone other than their specific loved one. So this was extremely important to define, not just through conversation and education with the staff, but through the guidebook as well. It allowed caregivers to clearly understand their scope while providing reassurance for frontline staff on the exact role this would entail. Next slide, please. And so what you will see here is a bit of a process map that we developed alongside, again, our wonderful patient advisors, our patient experience participants. So this first step in this process is a request is made for the Essential Caregiver Program. This request, it could be made by the patient themselves, their substitute decision maker, any team member could really identify that this would be a good candidate for the caregiver program. All intake was done centrally through an electronic email inbox, which our team monitored daily. Then we would ensue with intake. So that would include discussion with the healthcare team, identification of the caregivers, providing educational materials, and onboarding. So once the caregiver was accepted into the program, there was a detailed education program they went through. Then self-screening. So upon arrival at the hospital, screening and wearing their Essential Caregiver ID, which then went into provision of care in collaboration with the healthcare team, and eventually to discharge from the program. Next slide, please. And so as we talk through our program launch, as you saw, there was quite a bit of planning that went into the pilot, and we targeted pilot areas with long stay patient populations. As Michelle reviewed, there are many different components to the operations at our hospital. And so we decided to start with those areas that saw the highest need for caregivers. We conducted touch points with program leadership on the rollout plan. Communication really is key. So just ensuring that everyone knew exactly what was to come and preparing them with all of the materials and information beforehand. We also conducted week-long education sessions for frontline staff. And again, that clear communication through rounding at quality huddles, a lot of open communication and addressing concerns through on-the-hand Q&A. We created an internal and external communication plan so that all staff would be aware as well as how we would get the message out to our community members. And we offered heavy support from the quality and safety team. So one thing we realized, it was a great concern from staff if this would increase their workload. So what we offered was that we would monitor the intake, we would monitor the inbox, we would help support the education of the caregivers so as not to create any additional work up front for the frontline staff. And of course, as with any project, we trust the QI process. Throughout quality improvement, we know it won't be perfect right away, but we're always willing to press go and make changes as we move along. Next slide, please. And so I will pass it over to my colleague, Elaine.
Thanks, Campbell. So as with any QI project or initiative, an evaluation plan was developed to measure the success or effectiveness of the program. The program was rolled out to 11 inpatient units across 3 sites over 10 months. We looked at and developed process measures, looking at the number of individuals who were enrolled or applied to the program, the number enrolled, the percentage of requests acknowledged within 1 business day. We also looked at our outcome measures, and we also looked at balancing measures, looking at impact on staff. We also collected data through a weekly caregiver survey related to their feedback, and which identified that on average, caregivers were spending about 5 to 15 hours per week on site, that the caregiving periods of highest presence was between 7 a.m. and 1 p.m. and afternoons between 1 p.m. and 7 p.m. A lot when we looked at the main care activities, a lot of that demonstrated cognitive stimulation at 88.9%, activities assisting with activities of daily living, 77.8% of our caregivers, and emotional well-being, communication assistance, and supporting walking and light exercises. Next slide, please. This data was reviewed on a monthly basis, and we developed a scorecard just to continue monitoring the rollout. So I've identified our process measures. We looked at the monthly summary of enrollment, looked at enrollment by area as we spread and scale, looked at the days of the week even where we saw the highest number of caregivers, and I already talked about our main care activities, and then we monitored key project activities that we had outlined for this project, as well as the caregiver feedback that really spoke to our outcome measures. Next slide, please. Some of the feedback that we heard from patients and caregivers related to the program are listed here. So this program brought a lot of comfort to our mother and to our entire family after only being able to see her for an hour a day. It's a win-win situation for all of us. There are so many benefits to this program, including having the ability to communicate in your language and help the patient express their cultural views and opinions. Staff showed me the physio exercises my dad needed to complete and let me record them so that I could share the videos with my mom and brother. So here, just highlighting the benefit of the program and caregiver feedback in terms of, how they received the program and felt it helped them, stay connected with their loved ones during their hospitalization. Next slide, please. So go ahead, Cameron. I'll hand it back to Cameron.
Thank you. So I'll share a few of the learnings as we went through this process. Thank you, Elaine, for sharing that feedback from the caregivers who were enrolled in the program, which I think is the biggest success measure of all. Some of our learnings throughout the rollout and spread and scale included communication of shared purpose early on. So we were fortunate to have a strategic alignment from our senior leadership as the rollout and spread and scale of our essential caregiver program was included on the strategy map for this past fiscal year. So having that shared purpose and being able to talk through that with all of our stakeholders was extremely important. Setting those mutual expectations and addressing staff concerns. We did recognize that there was hesitation from staff after such a long period of having no visitors and no caregivers on site to slowly reintroduce these back. So being very clear about what was included in the program and how this was different than visiting really helped us to set the stage for what was to come. We created mechanisms for open feedback. So as I mentioned, prior to the rollout of the pilot, we had frequent touch points with program leadership. We continued these touch points throughout the spread and scale. We would connect back with teams to see what was working, what was not working, and to share the results of the caregiver survey. Of course, we had to remain agile. So as Michelle discussed at the beginning, there have been so many changes that we all have been through in healthcare over the last few years. So we had to continue to evolve as guidelines evolved. and make small changes as we went along. And of course, collecting data was crucial to showing the success of the program. It really allowed us to, as we went on, to evaluate progress and identify challenges and track success. And the really great thing is, as the pilot continued and then spread and scaled to other areas, we were able to share the learnings from the earlier rollout sessions. Next slide, please. And I'll hand it back to Michelle.
So this is our last slide, and really for us, looking ahead, we've had a lot of discussions on what next. As Canwell described, the program has been very successful. It is well sustained. The operational leaders are now able to sort of maintain the program. But as a department, we're thinking, how do we evolve this? How do we make this live and breathe across the organization outside of the pandemic? We have seen a number of enrollments in the program decrease over time. So the questions that we raise with our teams is, how do we continue to evolve what we have created? A lot of the education and tools were around infection prevention and control. How do you keep yourself safe in hospital? So we're actually looking for opportunities to partner with the caregiver organizations, community organizations, as well as our internal patient education committee to determine how do we make this a living and breathing program that continues to evolve outside of the pandemic. As we move now to this endemic stage, what are the next steps for us as an organization? We really don't have the answers yet. What we do know is we want to sustain the gains we've made, but we also want to evolve the program enough that it continues to provide support for caregivers and also highlights our commitment to patient and family-centered care across the organization. So that's it for us.
Well, thank you very much for this presentation. I have been madly taking notes. I really was such a thorough rollout and very insightful like caregiver examples, which I think really speak to the importance of this initiative. And I'm going to open the floor up to our participants to see if anyone has any questions. I'm going to stop sharing my screen and bring our panelists back on screen. You can unmute show your cameras, then we can see if anyone has any questions. Please feel free to unmute yourself or post a question in the chat. The floor is open. Oh, I see Sonia has her hand up for a question. Please just unmute yourself and share it with the group.
Hi, thank you. Excellent presentation. I really appreciate it. Great information. I work for Horizon Health Network in New Brunswick, and we are currently revising our family presence policy, and we do as well have an education component to our work. We call our program a designated support person program. Is it mandatory that all of your caregivers have this education before they can become an essential caregiver?
Sure, I can answer that question. Yes, it is mandatory. So we require that each of the caregivers reviews the guidebook in full prior to enrollment, as well as there are links to online videos that they must watch. There's a link to a policy as well that they must review. And then part of enrollment in the program is signing on the commitment form that they have completed that education and reviewed the required materials.
And one additional question, we have just completed a survey with our healthcare staff around our current program. And one of the resounding themes that has come up over and over again is the view of emotional support versus the physical support that can be given, and that it is not seen to be the same value. Did you find that in your organization, that it's that there's a difference there of the value that the emotional support provides?
That's an interesting question. I think that even prior to the pandemic, we had established a culture of patient and family-centered care, which really does focus on the soft skills and establishing a connection between patient and provider and ensuring that patients feel their loved ones are part of their care and they're included in the care. So I'm not sure, and maybe Michelle and Elaine can jump in. I don't think that it was a huge obstacle for us, but we did have to bring that back up in communication with staff.
I think just to jump in from my observations, if you were a caregiver providing support from a physical perspective, I think staff saw this as more valuable because it helped from a workload perspective. I think though for patients, really when we talk about the type of emotional support, I think staff were also open to this. We would hear staff that would say, you know, for example, mom needs her daughter to help her settle at night, or, you know, this is a surgical patient, you know, who benefits from her husband being present. So there was that emotional as well as physical component, but I think it was a good balance, and staff were really very open based on the needs of the patients, you know, to count them as caregivers. And we did want to track, you know, caregivers who came in, was it for emotional support or to provide some sort of physical support with activities of daily living? And what we found really, it was a combination. Oftentimes it was they provided both types of support versus one exclusively.
Thank you. And just one further question, will the PowerPoint, will you be sharing that? And if we have questions down the road, are you open for us to contact you?
Absolutely. We're always willing to learn as well. And we recognize there's room for our program to evolve. So we're looking actually to speak to any organization that wants to talk to us, you know, because we're really concerned that moving out of the pandemic, you know, the traction that was created, we may lose it. Or what do we need to do differently from a caregiver perspective to make the program, you know, even better than it is right now? It served its purpose, but what more can we do?
Thank you.
Thanks, everyone, for your thoughtful answers. We have a couple of questions in the chat from Chitra. She's just wondering, who are the participants in the Quality Huddle?
Oh, that's a great question. So we have implemented team quality huddles across our organization, and that includes frontline staff. It includes everyone present on the unit at a designated time each day. So it really brings together a cross-functional team of all of the staff in a given unit. So there's different measures that are discussed at these huddles, and it also provides an opportunity for us to talk about new programs and initiatives.
Great, thanks. I have another question in the chat. Marie Lewis is wondering, you mentioned 10 inpatient units. What were some of the types of units that this program was rolled out in, for example?
I think so. As in the presentation, we identified our long stay patients. So complex continuing care, palliative, stroke rehab, ALC, reactivation, and some of our longer stay patients that are on our med-surg units.
Just to jump in, we also rolled out to our surgical program as well. We didn't roll out to our children and childbirth area, I believe, but to our surgical program. We struggled a lot from a surgical perspective with visitor restrictions. So we recognized that this the surgical team would have really benefited from the essential caregiver program. But our primary focus initially was in those medicine areas.
Yeah, and we also included ICU as well.
Thank you. And I see Yelena has her hand up. You can just unmute yourself and share your question.
Wonderful. Can you hear me?
Yes, we can hear you.
Okay, perfect. So I have two questions. First, a comment. This is wonderful work, and I'm so impressed with what you've accomplished. The dashboards look phenomenal. And of course, just the principles of this are everything that we all believe in. But two questions that we are addressing in our own organization. The first is, do your teams document the interventions or the support that the caregiver is providing on a shift? For example, if they're mobilizing somebody or performing care. So that's my first question. And then my second question, of course, the concern in these things always is that somebody could have an untoward event, be injured as a ECP, or a patient having a negative outcome. And have you had any experience like that?
I think with regards to the first part of your question, the caregiver survey, we had the caregivers identify the activities that they participated in while they were on site. We didn't have a specific survey question for our staff related to that.
So on a shift, for example, if it's today and I'm the nurse for that person, I wouldn't be documenting that ECP for Yelena performed ADLs.
Yeah, we didn't set that expectation with the program, but from our perspective, from a documentation perspective, we would expect the staff to document that an essential caregiver was present. As part of the program, the essential caregiver was also attached to a staff member on the unit who was their key point of contact. So I believe that interaction would have been documented. And in terms of adverse events for essential caregiver, we haven't had that experience yet, touch wood, and hopefully we don't have that experience. I don't know what else to say from that perspective.
That's wonderful. Thank you. Those are excellent answers.
Thanks. And we have another question coming from the chat. Sarah is asking, I noticed a big difference in the amount of caregivers that applied versus those that were onboarded. Can you describe some of the reasons for this?
Sure, I can touch upon that. And this was always an interesting discussion point because our scorecard was shared widely each month, since this was a big initiative across our organization. And so in some of our longer stay patient population areas, much of the time as a caregiver applied, they were accepted into the program. In some of the shorter stay patient areas, we found that by the time a caregiver applied, even with rapid turnaround to communicate with them and to explain the education, by the time that we were able to accept them into the program, their loved one was being discharged or moved, or there were other plans put into place. And so much of the time, if a caregiver applied and was not enrolled, it's because their loved one was discharged before we could enroll them. But the great thing is we were still able to provide resources to them so that they could take that information and still use it when their loved one was discharged home.
Great, thanks for sharing all this information. Just looking, I have a question as well. You really showed that the leadership in your organization was really committed to the reintegration of essential care partners. Any guidance on how you were able to make it so central to your strategic plan?
So I think from a strategic plan perspective, one of our pillars are around delivering an extraordinary patient experience. And, one of the things that we do every year is create a roadmap associated with the tactics that we're going to implement. And we did have this on the implementation of the Essential Caregiver Program was listed on our roadmap. It was also listed as a strategic initiative. So that meant that our senior leadership team fully supported and were committed to move in, to implement in this program. And once there's commitment from the senior leadership team, I think that's a big win, because, you know, they're able to speak to it, they're able to sort of walk the talk and show that, yes, we are committed to patient and family-centered care. We recognize that we're in challenging times, but we need to meet the needs of our patients and families. In addition, the scorecard was also shared and discussed at our senior leadership team huddle in a rotational basis. So we have an executive sponsor that was assigned to this initiative as well, and their commitment was to reporting out on this initiative. So this was talked about from the senior leadership level. We also reported out to the board in terms of the work we're doing. And of course, so from the board to the ward at the unit level, discussions at these team huddles, team quality huddles. So I think the success to this is that everyone was talking about it, and it was our primary focus from a patient and family-centered care perspective for a full fiscal year.
Sorry, sticky mute button. I'm just checking the chat for any other questions or any raised hands. We have just a couple more minutes. Are there any last minute questions people would like to ask our presenters today? We'll also be sending out the recording with our Essential Together email and posting these resources and information on our Essential Together website. So just checking to see if there's any other questions. That was a really great follow-up discussion to a great presentation. I really thought, learned a lot about the data. I thought the dashboard was beautiful and such a helpful tool in showing how important this program is, blended with those great caregiver quotes. So thank you very much for sharing all of this information with us today. I'm just going to move on to like our little wrap up housekeeping. I'm just gonna go back to sharing my slides, and just to take me one moment here. Here we are. A little multitasking today. Yeah, so thanks everyone for joining us today. And I'm just put up here that we letting you know about our upcoming huddle in March. On March 15th, we will be hearing from the family caregivers of British Columbia, just furthering this conversation of how important caregivers are as members of the healthcare team, as well as in facilities like Oak Valley, but also in the home and community. So we are also looking forward to that session in March. So thanks everyone. We've reached the end of our discussion today, and we look forward to seeing you in March.